patients and start high flow nasal cannula and then oxygen therapy and then awake proning, and this is useful. Apart from this, we use antibiotics, erythromycin and nebulization and all measures which are really used for these patients. We are in the process of designing a locally manufactured high flow nasal cannula which can deliver from 30 to 60 liters of oxygen per minute for these patients. And secondly, we are in the process of designing UV light air purifier which will be placed in this area to reduce the size, reduce the load of virus in that room where you have patients with COVID. And we have designed a box which is made of transparent glass for intubation of these patients, because these patients, when to intubate, there are chances of aerosol spread, and all the colleagues who are intubating these patients usually get infected. So we made that box from where you can put only 2 hands inside and you can intubate the patient with RSI in these patients. So coming to other points, protection, most of the time everybody is using N95. For our setup where we are dealing with the COVID-19 confirmed patients, we send our residents and we go there with proper N95 original mask and with super added or boosted with one surgical mask which can be discarded over there along with goggles and PPE. So let me introduce one mask if you are visualizing this. We are using now this mask for our COVID area where we have designed COVID ICU. This mask is specially designed for that area. It has 2 filters on both sides and it has a very tight fitting. You fit these filters on the sides and put it like this. It's very difficult to breathe from this because it has a very tight fitting, but it has a definite protective role in our professionals who are dealing with the corona patients. Along with this, we have 2 types of goggles. One goggle we are using routinely in operation theaters and emergencies, and we have eye shield goggles for patients, for our colleagues who are dealing with the corona patients in HDU. So these are our protective measures which are very effectively practiced in our setup. And Alhamdulillah, we are we had 25 beds initially to start with for these patients, where we put 6 ventilators for these patients, which were enhanced up to 10 ventilators for this corona area. And now the non-ventilated area is up to 40 bedded, and we are extending our ventilated area from 15 bedded ventilated area to 30 bedded ventilated area, because we are getting too much pressure and load in Jinnah Hospital, Lahore, and we are alhamdulillah coping with all this with my team, which is working very enthusiastically and is always with me round the clock, and my residents are working alhamdulillah very with dedication. So I was just being the question, one question was about HCQ. So it is not recommended in our setup for therapeutic use. It can be used prophylactically, and I am recommending it prophylactically 400 milligram once a week for 3 weeks. Secondly, we are using methylprednisolone steroids in these patients, and this is very useful, 40 milligram of prednisolone if CRP level is less than 100. And if CRP level is more than 100, we are using 40 milligram BD. And secondly, we are using anticoagulant, which I started with 40 milligram being on the using on the lower side subcutaneously. And we are monitoring the D-dimers. If the D-dimer value is less than 1000, we use 60 milligram or 40 milligram subcutaneous OD. And if the D-dimer level is more than 1000, we are using it in PD dosage. Apart from this, we are using high flow nasal cannula, and our ventilation strategy is lung protective strategy ventilation. So with this, I think I finished my opinion, and if there is any question, I'm ready to take that.
Thank you very much, Professor Ashraf Zia. And I would again refer to Dr. Saif Rehman because I have a question and very pertinent question about herd immunity. Sir, what is herd immunity and how can we rely on our herd immunity? So we are having a very friendly lockdown here in Pakistan, and I think that our authorities are now basically relying on herd immunity. What's your take on that, Dr. Saif Rehman, please? Hello? Yes, Dr. Saif Rehman.
Hello?
Hello, can you hear me?
Yes, I can. Sorry,
Did you
after
get my
the
question?
inspection, I was unable to unmute.
Did
Yes,
you
so
get
you
my
asked-
question?
Yes.
I want to know your take about herd immunity. What is herd immunity and how we can rely on herd immunity on mass level to combat this pandemic?
Well, the herd immunity obviously is a concept that everybody will get infected and they basically will come immune to the disease, and people who will survive will be immune. The people who will obviously who will get infected and cannot or does not come out of it, obviously will lose their life. But it's a mass immunity, which is the idea which initially I think in Britain they were trying to follow, but that turned out to be a very bad decision by the UK government, and obviously they asked the mass casualties they experienced there. So I mean, this herd immunity is something which in countries like Pakistan or low socioeconomic countries, there might be somehow difficult to prevent it, because as you know, the current government policy is they're already flexing the rules for lockdown, and people are already on the streets, and somehow even if they're not doing it or declaring it, but they are heading towards herd immunity. Not sure how much it will affect in Pakistani socioeconomic circumstances, but obviously it may or may not go in either direction, and it can cause a lot of fatalities or, God forbid, a lot of deaths or otherwise. But I think our current criteria for lockdown and flexibility should have been implemented more strictly, and I would rather vouch for that. They should not have let lockdown go easily down so quickly and so early in the phase. They should have actually put more criteria for at least a couple of weeks more, or if not month.
Thank you very much, Dr. Saif. I was, listening to some of the international media correspondent from CNN other day on that television, and she was actually doing some research on the ways and means which were adopted by China government to combat this pandemic. And she came to conclusion that there were three basic factors which, made them fight this pandemic. Number one was the strict lockdown. Strict lockdown means a curfew-like lockdown. And she categorically said that there was no concept of herd immunity over there. No health personnel was even talking about the herd immunity. Number two, using mask was a culture over there. If someone was not wearing mask in the public gatherings, he was, looked in a strange way, and she was forced to wear the mask. And third, the people had a very firm belief on the policies of their government, and they acted upon accordingly and religiously on the precautions and all the SOPs which were set by the governments. So China didn't rely on the herd immunity, and the result is quite evident in front of everybody.
I agree. We shouldn't rely on it. I mean, this is something which will happen eventually, but we should not rely and go for it and just try and just relax every rule and then just go on the daily life and just forget about this severe pandemic. And like here, obviously the surgical mask, as I said, mask is mandatory here it's been more than a month or 2 months now that the public place you have to wear a mask wherever you go, otherwise you get hefty fines here. And Pakistan should have followed the same guidelines.
There is another question. Can COVID transmit through fecal-oral route?
Not that we have heard so far, and I think there's not much evidence about it.
I think it can be transmitted through oral route because you take the sample from nasopharynx and oropharynx, and it can be transmitted from oral route as well.
Thank you very much, Professor Ashraf Zia. There is another question from Dr. Shahzad Tahir. Dr. Shahzad Tahir is the General Secretary of Pakistan Academy of Family Physicians Islamabad chapter. First, I would like to, read his question for you, and afterwards, I would like to take his comments on today's program as well. Dr. Shahzad Tahir, can you hear me? First of all, the question from Dr. Shahzad Tahir is that where we can get plasma therapy in Punjab, and does it have an impact on patients with comorbidity? Dr. Shahzad, you can have this plasma therapy in Punjab at University of Health Sciences in Lahore. I'm not sure is it available in Rawalpindi Medical College or not, but it surely is available at University of Health Sciences, and you can comments on today's program as well. Dr. Shahzad, Pakistan Academy of Family Physicians, Islamabad. Dr. Shahzad Tahir, can you hear me?
Having some problem with audio and video. I think.
Okay. So we have another very esteemed participant over here. It is Dr. Nahid Nadeem. Dr. Nahid Nadeem is the Lady Vice President, Pakistan Academy of Family Physicians, and she is incidentally the first female plasma donor. She, had COVID-19 positive test, and she was placed in quarantine in the hospital for 10 odd days, and afterwards she has donated her plasma at University of Health Sciences. Incidentally, it's another coincidence that her plasma was infused to another family, veteran family physician from Sahiwal, and is recovering, in a very, very rapid way and a very rampant way. Dr. Nahid Nadeem, can you share your experience of COVID-19, first as a patient and then as a donor of plasma?
Thank you, Dr. Tahir. Assalamu alaikum, Dr. Saif and the two panelists. I had got corona at the end of the March, and I was asymptomatic at that time. And by the grace of Allah, I got 2 tests negative by the end of 2 weeks. Professor Javed Akram contacted me last week, and he said, you have to donate a plasma to a seriously ill patient. So I donated my plasma in University of Health Sciences last week for that patient from Sialkot. He was also a general family physician and 85 years old male patient. And we have all noticed that he has improved a lot with it, especially his breathing problem. Now my message for all the doctors and common public is that they should donate their plasma to the other patients who need it to serve the ailing humanity. Thank you.
Yes.
My one question to Dr. Saif, please, Dr. Dr. Saif, can you hear me, please?
Yes, I can.
Okay, we are practicing this plasma transfusion in Pakistan. Have you practiced this plasma donation and transfusion in your setup, and what was the outcome? Because at this time, right now, there are no conclusive results, and there are no gross studies. We have only limited data, and we are always, everybody is saying that you should search about your treatment and your data and your trials. So what was your fact about this plasma transfusion?
We haven't got much data at the moment, but it was only authorized recently, and it's basically done in critical care level or HTU level. So we're not seeing it in our emergency department, but we have come to know that they have started recently with the strict criteria for some patients, but it's too early to have any data so far. But it's a part of a research that they're going on. I might be able to share some more data later, maybe after a few weeks or maybe a month. But at the moment, I haven't got any data at the moment.
Okay.
It has been authorized only
Dr.
recently.
Thank you very much, Professor Ashraf Zia and Dr. Saif. With that, we are coming to the conclusive part of our today's program, and it was really a wonderful experience sharing by all the colleagues. ना कोई इलाज ना दवाई है, ए इश्क तेरे टक्कर की वबा आई है. With that, I sign off and I hand over the program to Mr. Asad Umar to take you to the end of the program. And with that, thank you very much, everybody, and take care. Over to Asad Umar for the conclusion of the program. Thank you very much.
Thank you very much, sir. Thank you very much, Dr. Saif Rehman, for a wonderful presentation. And thank you very much for the panelists, Professor Dr. Ashraf Zia, Dr. Tariq, Mian, and a very special thank to Dr. Naheed Nadeem, who just not only basically gave her plasma to treat patient, and she's also a physician and working on a front line. So at the end of the day, I would like to thank all the our frontline doctors, frontline staff members and paramedical staff, because they are risking their life to this deadly virus and providing a very safe passage to the patients, and they are basically risking their own life. So this is a very esteemed way to put this on. I would like to present our most utmost efforts and our support as a pharmaceutical industry in support of the doctors and frontline soldiers. We would be helping in any way we can to support you. And in the end, I would like to request Mr. Basit Hameed, who is basically business unit head of Ferozans, to please thanks the panelist and the moderator of the day, Dr. Tahir Chaudary, and concluding remarks.
Thank you very much, and really I have no words to pay thanks to all the frontline soldiers, doctors, especially my special thanks to Dr. Saif, that who, despite of his emergency duty, he spared time for this really noble cause. Thank you very much, Dr. Saif. Thank you very much, Dr. Ashraf Zia. Thanks a lot, Dr. Tahir, Dr. Tariq, Mian, and all the participants who participated. I wish you all the best, and I wish you all and for your family very safe and happy life. Thank you very much, and Allah Hafiz.
Thank you very much. Allah Hafiz.
The rostrum to our worthy speaker, Dr. Muhammad Saif Rehman from Abu Dhabi, to enlighten us with his expertise in that regard. Over to Dr. Muhammad Saif Rehman.
Assalamu alaikum, everyone.
Walaikum assalam.
Can you hear me?
Yes, sir.
Okay. First of all, obviously, thank you very much for giving me this opportunity. Thanks for Basit and Frontline for arranging this webinar, and Pakistan Academy of Family Physicians to give me this opportunity to speak to you all. And let me just show my screen. Okay. As introduced by Dr. Tahir, my name is obviously Muhammad Saif Rehman. I'm the consultant emergency physician at Cleveland Clinic, Abu Dhabi. To give you just a bit of a background, obviously I hail from Pakistan, I hail from Multan, and I graduated from Leicester Medical College, and I'm trained in UK as an emergency physician. I moved to UAE only 8 to 9 months ago, and since then I'm working at Cleveland Clinic. Today, I will give you a bit of a perspective of how we're dealing with COVID-19 in UAE and how we're dealing, especially in emergency setting, which obviously you can replicate in any frontline clinical setting, whether it's a family physician clinic or medical center or emergency department. This is where I'm working at the moment. Cleveland Clinic is situated on Maraya Island in Abu Dhabi. It's a fairly large hospital, 664 bed with 72 ICU beds. And it has 14 institutes covering almost all specialties except orthopedics and pediatrics. We are a center of excellence and Center for Stroke, for STEMIs, for respiratory and critical care, and for digestive diseases. This is the emergency department where I'm working. It is a 41-room ED with 2 resus rooms, 36 normal patient rooms, and 3 CDU beds, clinical decision units, where we can keep patients for up to 24 hours for observation or pending investigations. So our objective today is just to give you an workflow overview for suspected or confirmed COVID patient who come to the emergency department or any frontline clinical setting. So we'll go through some overview of the workflow as ED and whole, what's the streaming process is, how the streaming process and the workflow works in the hot zone, the cold zone, and our PPE policy, and briefly about patient assessment. I won't go into detail about the clinical things about COVID, but to give you an overview, and also then discuss the disposition criteria we are following and some home isolation guidelines. And then briefly about how we're taking care of our staff and the colleagues. So ED workflow currently works like if the patient comes to the ED, obviously they get registered at the front desk, and then they are directed to the streaming. I'll come to the streaming later, what this involves. The streaming is basically where we get patient differentiated and then sent to either the COVID zone and non-COVID zone. So the whole ED is now divided into a cold and hot zone. So patients do not cross over to prevent this decontamination and cross-infection. So that depending on the streaming criteria, the patient is sent to COVID zone or non-COVID zone. Similarly, if the patient came by ambulance, they go through a streaming process as well, but their streaming process is obviously done pre-arrival by telephone. So they get triage and streamed even before arrival. One of the paramedics can go and register at the same time, but the patient get offloaded into COVID or non-COVID zone. At the moment, we're following a strict policy. There's only 1 patient is allowed in ED with no attendant or relatives on either side to prevent public from getting more exposure. Very few exceptions, like patients with very elderly patients who are delirious or they need family to get a better idea of the history or physical support, they can be allowed only 1 patient. Otherwise, it's only 1 patient without any attendant on either side. Streaming, for people who are not aware of this term or not using it in, I'm not sure it's being used in Pakistan or not, but it's basically a process for allocating patients to different physical areas or services or pathways in order to improve efficiency and effectiveness. The main objective is that the patient is directed to the correct service and the correct person to manage their needs. So it could be whether it's been sent to ED, it could be whether it's sent to an outpatient clinic or any other setting, or directly referred to a specialty clinic. And it has to be effective and brief to avoid any queues, especially in ED, especially in this pandemic and these area circumstances. So the streaming criteria has to be strict. The good quality streaming will obviously involve brief history and performing vitals and combining triage or calculation of early warning scores can give you an idea. So the streaming is the process where you differentiate patient to different zones, and triage is the process by which you would categorize patient who needs to be seen first or urgent or semi-urgent or can be seen a bit late. So ideally it should be done within 15 minutes of patient arriving in ED. And it has to be quick, and you have to be aware of your capacity issues. You don't want long queues outside. You don't want patients to be waiting in the waiting room. And obviously, especially with the COVID-19, you don't want congestion in your waiting room or at the front desk. So the criteria for the streaming process in COVID-19, which we are following here, is every patient who comes in, we need to find out whether they fit the criteria for COVID-19 or not. The first criteria is anyone with any new respiratory symptoms, whether it's cough, wheeze, or breathlessness, sore throat, hoarseness, hypoxia, flu-like symptoms. Any of those symptoms, they go to COVID zone. If they're worsening of a pre-existing respiratory condition like asthma, COPD, or bronchiectasis, obviously they also fit the criteria for COVID-19. Or if they have fever above 37.8, whether it's unknown focus or fever with headache or fever with GI symptoms, diarrhea and vomiting, they also get sent to COVID zone. However, the patient has got fever with a confirmed focus like possible UTI, like patient coming with dysuria or flank pain, you're suspecting pyelonephritis or UTI, they're sent to a non-COVID zone. But pyrexia of unknown origin or headache or GI symptoms, they get sent to COVID zone. In UAE, the surgical mask or a mask is compulsory now, and in every when you go out to the house, it's on public places, everywhere the mask is mandatory. And same criteria is being followed in the hospital. So either patient is going to COVID zone or non-COVID zone, all patients are given masks to put on. So they have a surgical mask on, whether they are in either zone. The one thing to remember is the patient, yes.
Dr. Saif, can you speak loudly? I think you are using a headphone. If you are using headphone, then please remove them and talk directly to your laptop. Thus we can hear you loudly. Right now, your voice is little bit low. Thank you.
Can you hear me?
Yes, Dr. Saif.
Is it better?
Yes.
You want me to repeat this, or everybody is okay with the?
Absolutely right. Fine.
So one thing to remember is the patient can be sent to either zone. There's some ambiguities in this criteria, so somebody can be sent wrongly to a different zone. So if they're sent wrongly to a non-COVID zone, or for example, they develop any criteria for COVID triage while they're in non-COVID zone, or there's a clinical signs of pneumonia or radiological signs of pneumonia found out later in the non-COVID zone, then patient needs to be transferred back to COVID. And then full PPE policy needs to be followed. So the staff caring for the patient should take the patient back to the COVID zone, because the safety of the staff and the other patients in non-COVID zone.
Dr. Saif, again, your voice is unclear. Please check it again.
Okay, let me just check this. Should be on the full. Is it okay?
Okay. If you are using mic, then using headphone, then speak loudly. Otherwise,
I'm just using the laptop mic now. I'm not using headphone.
I think previously your voice was better as compared to right now.
You want to go back to the headphone?
Yes.
Is it better?
Yes, sir. Just please speak loudly. Thank you.
Okay, sorry about that. So yes, the patient can be transferred from non-COVID zone to a COVID zone if they develop any criteria of triage criteria or they have pneumonia. But patient cannot be transferred from COVID zone back to non-COVID zone, because to prevent any contamination and cross-infection. There's only one-way process from COVID to non-COVID, non-COVID to COVID, but not back from COVID to non-COVID zone. So this is a streaming process we follow here, and then differentiate patient who goes to COVID and non-COVID zone. The streaming process in COVID is very important, especially because it has to be, and it is very important to obviously safeguard staff from unexpected exposure. You don't want to expose your staff in the non-COVID zone by sending a wrong patient there. And at the same time, it's important to safeguard the patients from unnecessary exposure. You don't want to send a patient who's elderly or immunocompromised or with high-risk comorbidities to a hot zone where they got a simple problem which can be dealt in the non-COVID zone. So it's very important to safeguard both staff and patients. And therefore, the streaming process has to be very strict and uniformly implemented. So the workflow on the COVID zone or the non-COVID zone would remain the same like you usually do, but it's the workflow on the COVID zone which is a bit different. So anybody coming to the hot zone is suspected or confirmed COVID patient unless proven otherwise. So when they came to the zone, they get into 3 different categories or 3 different rooms. If they're very critically ill, obviously they go to recess. If they're stable patients who need assessment, they go to normal patient rooms. And if they have any aerosol genetic procedure or oxygen requirement or nebulizer requirement, then they go to negative pressure rooms, which are obviously limited. We have 4 in our ED, and the rest of them are normal patient rooms. Once they get offloaded into those rooms, obviously they get assessment by nurses, and then the physician assessment comes into play. All the staff on the hot zone are wearing full PPEs. I'll come to the PPE policy later. So even the nurses, the physicians, the clerks, porters, everyone is wearing the full PPE on the hot zone. Once this is overview of the workflow. So once the assessment is finished, obviously we need to decide about disposition. And there are 3 types of dispositions we are currently working. The patient either go home for home isolation. They obviously can get admitted. Because we are the tier 3 center for COVID patients. So we are only seeing patients who are very sick, who requires step down unit, SDU or critical care unit input. So they get admitted at CCAD, otherwise they get transferred. There are tier 1 and tier 2 hospitals in UAE which take patients who are mildly symptomatic, who do not need critical care or HDU care, so they can be transferred to those hospitals. So I'll discuss these criteria later. The PPE policy which we are following here is this. I know there's a global shortage of PPEs everywhere, and every country has their own problems to deal with. This is suspected patient here are either given 2 different kind of categories, enhanced droplet or enhanced airborne. So if the patient is suspected, we put on the sign for enhanced droplet precautions, and everybody entering the room should have at least bare minimum a surgical mask with goggle or a full face shield, gown and gloves. But anybody with confirmed COVID-19 or anybody with severe acute respiratory illness or people who are requiring aerosol genetic procedures, they would have N95 with goggles or face full shield, gowns and gloves. We are now also using KN95, which is the Chinese version of N95s. They're also being used simultaneously. And everywhere else in the hospital, for clinical or non-clinical, surgical mask is mandatory anyway, even if you're not dealing with the patients. This is the current PPE policy which is being followed. Coming to assessment briefly, so nursing assessment is the bare minimum requirement is obviously heart rate, blood pressure, respiratory rate, SAS, temperature, GCS, their blood glucose and EKG. It's a bare minimum assessment we do for all the patients. Physician assessment obviously followed the normal clinical assessment which everybody does, getting the history of presenting illness, review of system, the examination, investigation, and then medical decision making. And then we decide about disposition. I will not go into details of the clinical assessment apart from just discussing a bit criteria about investigations and some radiological protocols which we follow, which give you an idea, the front line, which things you should perform. So investigations for COVID in emergency department, apart from baseline investigations like CBC, basic metabolic panel, hepatic panel, CRP, it's a good idea to add at least venous blood gas, which gives you an idea about patient is shocked or not and oxygen requirements, and even the quick overview of the electrolytes. D-dimer we would now doing in every patient with suspected COVID-19 because it has to be found elevated in all the patients with COVID-19 mostly. Blood cultures, if the patient fits the criteria for SIRS, they get blood cultures. Anybody with chest pain, tightness, troponins, and patient with dyspnea get BNP. And then imaging, we either do chest X-ray, bedside ultrasound, or CT scan. And obviously, all the patients get COVID-19 swab, nasopharyngeal and oropharyngeal. If the patient getting admitted for definitely, then we do these extra tests, which are basically to save patient to have another needle prick. So we can request these only if patient get admitted, which are important in patients for COVID-19, the G6PD, LDH, ferritin, fibrinogen, CK, and procalcitonin. But these are only ordered if the patient get admitted. These are some laboratory markers which are found to be correlated with disease severity in COVID-19. You may all know about this, but just briefly, the CBC can show lymphopenia, thrombopenia, this severe disease. AST/ALT and CK is found to be high in COVID-19. As I said earlier, D-dimer is also found and predictor of increased mortality. LDH also is found to be associated with severe disease. CK is found, and idiopathic rhabdomyolysis has been found in the COVID-19 patients. Procalcitonin could be normal in viral infection, but in co-infection, bacterial infection, found to be high. Same with ferritin, IL-6, and BNP troponin, depending on chest pain and dyspnea. We used to send initially respiratory viral panel for every patient who was coming with COVID-19, but now we have stopped doing it. It's only 6%, 22% where you can have co-infections, but we're not doing it anymore because it doesn't affect the treatment. So treatment for other influenza or flu-like illnesses would be symptomatic anyway. So we stopped sending respiratory viral panel. We only do COVID-19 swab and not send influenza panels. This is a radiology tool which is very good to be followed. Requesting imaging for COVID-19 patients is developed by British Society of Thoracic Imaging. And this is a good handy tool to decide which patient needs chest X-ray and which patient needs CT scan. If we follow it, is basically if only suspected patient who have clinical assessment and labs. So most of the patients will have fever, at least 50%, or 80% have lymphopenia. If they don't have either of those, then it's very unlikely this patient has got COVID. However, if the patient is seriously ill with the stats of less than 94% or the new score of more than 3, then they get the chest X-ray. The chest X-ray shows bilateral peripheral pacifications or fits the COVID criteria, then obviously they get treated for the COVID. And they get isolated or get admitted depending on disease severity. If chest X-ray is uncertain or normal, then you can request a CT scan. The CT scan shows COVID pattern, then obviously again patient get isolated or admitted. If the CT scan is also normal, then you think about whether this is non-COVID disease. And then patient does not need isolation. If the patient is stable with a SAS of above 94 or news is less than 3, then chest X-ray is only done if there's clinic indicated. So if there's any clinical finding on auscultation, then you do chest X-ray. Otherwise, it's not required. So for normal chest X-ray again goes to COVID-19 pattern, the patient gets isolated or admitted. For normal chest X-ray, they go home. So you see in this protocol that there's only very minimum requirement for getting a CT scan done. So even if your facility does not have CT scan, you don't need to be worried about because chest X-ray serves the purpose mostly. And CT scan is only needed in very few circumstances. So you can go and just follow this protocol and request only chest X-ray, which can be helpful in diagnosing COVID-19 patient and without a CT scan. The risk factors for COVID-19, everybody is aware of it by now, but we have divided into 4 categories and depending on different criteria. So from demographics point of view, it's age above 65 or patient is male. Second category is comorbidities. So anybody with cardiovascular disease, cerebrovascular disease, diabetes with more than 7.6% of HbA1c, history of chronic lung disease, kidney disease, liver disease, or anybody with immunocompromise fits the criteria for high-risk patients. Clinical vital signs is third category of risk patients. So anybody with saturation of less than 92% on room air, or tachypneic with 24, or heart rate more than 125, or considered high risk. And then there are diagnostic criteria. So lymphocyte count of less than 1, LDH more than 245, D-dimer more than 1, troponin more than 1, CK twice upper limit, CRP more than 100, ferritin more than 300, or 50% more than lung involvement on CT scan. They're all considered high-risk categories. So one patient has been assessed and manage in ED, there are three things you need to manage: to disposition patient to either home or admission or transfer to tier 1 or tier 2 facility. So depending on the criteria, you will decide about whether the patient can be sent home or need admission or needs transfer. We'll go through these criteria one by one. So for the home isolation, the patient can discharge home with follow-up as needed. So there should be no shortness of breath, not hypoxic, tachypneic, or tachycardic, age less than 65, no history of moderate to severe cardiovascular or lung disease or severe immunocompromise, no significant other medical comorbidities. Patients has ability to ambulate without severe symptoms, ability to return if they're worsening symptoms, they know when to come back to hospital, and they have ability to isolate at home. So they should have a separate room, a separate bathroom, which is not shared, and somebody to look after them. So they should have ability to isolate at home. Only if the patient fits these criteria, then they can be sent home. Otherwise, we get them admitted to tier 1 facility if they can't fit home isolation criteria, but they are relatively stable, asymptomatic, or very, very mild disease. So it's a tier 1 or tier 2 facility is a concept here, which is tier 1 basically for anyone who got asymptomatic or mild disease but cannot self-isolate at home. So they go to tier 1 hospital, which is basically they developed a field hospital here, and patient can be sent there. They do not require much clinical input, but they are just kept there because they are unable to self-isolate. Tier 2 facility is where patient requires some clinical input. They got mild disease or moderate disease, but they do not require STU or ICU level care, but they can be given antivirals or antibiotics and can be monitored closely. They are considered as tier 2 facility. So anybody with mild, persistent, or exertional shortness of breath or requiring care without any oxygen requirement considered as fit for tier 2. They have mild hypoxia, tachypnea, tachycardia. If they got age more than 65, but they should have stable signs, they can be transferred. History of moderate diseases, cardiovascular or liver or lung or immunocompromise with stable signs can be transferred. Or they have 0 to 2 medical comorbidities, mild to moderate chest exchanges, or they have inability to self-isolate at home. So any of these criteria can be transferred to either tier 1 or tier 2 facilities. If you don't have such facilities where you're working, then I would consider these criteria to be also criteria for admission. So I would combine these transfer criteria and admission criteria together and just admit patients because they need close monitoring. Admission criteria to tier 3 facilities, obviously, if they require high dependency unit or step-down unit or ICU level care. So for the floor level admission, the requirement is whether they're requiring oxygen, they're moderately shortness of breath or tachypneic, they have rapidly worsening symptoms, hypoxia, tachypnea, tachycardia, age more than 65 with hypoxia, tachycardia, moderate to severe disease with unstable vitals or requiring oxygen. Again, 3 or more comorbidities, and also need to consider about fragility, resources, and other risk factors under consideration for these patients. So we have got low threshold for admitting patients to tier 3 if they have any of those. Similarly, the patient who require ICU consult or admission is patient who are progressively increasing requirement of oxygenation, their hypercapnic respiratory failure, their septic shock, respiratory rate of more than 30, and then requiring 100% oxygen on non-rebreathe or high flow nasal cannula or requiring NIV, or age more than 70 requiring oxygen, or anyone with comorbidities who require supplemental oxygen. All of these criteria, then we need to consult with ICU for possible critical care admission. Patient management outline, I'm just giving a very brief outline which we are following here at Cleveland Clinic, but obviously every hospital and every country has got their different treatment protocols. All the evidence for these medicines and treatments are obviously ongoing and changing every day. So everybody's following their own criteria, but for us, Anyone with mild or moderate illness, we're only giving the supportive treatment, antibiotics and the supportive treatment, whether it's home or they are admitted at tier 1, tier 2 facility, they only get supportive treatment. So anyone with COVID-19 confirmed and have pneumonia, they get this treatment. The pneumonia that is defined by WHO, that they have got like signs of pneumonia, but no severe pneumonia requiring supplemental oxygenation. The first line we're giving is hydroxychloroquine here with Kaletra, which is lopinavir and ritonavir. Or second line is lopinavir, ritonavir combination Kaletra along with favipiravir. Only in the patients who are intolerant to hydroxychloroquine or have risk of increased QTC. So these are the first line and second line drugs for anyone with pneumonia. Empiric antibiotic therapy is given for all superimposed bacterial pneumonias. And the empiric antibiotic therapy is as per your local guidelines. We normally start with IV augmentin, and then depending on microbiology and clinical assessment, they can be changed. Anybody with the SARI, severe acute respiratory infection, they also get these treatment, tocilizumab, which is only authorized by infectious disease team. Convalescent plasma is also started here in few patients, in research going on, and so we are part of the research, and we are dealing some patient with this plasma, which meets certain very fixed strict criteria. And again, empiric antibodies are given to everyone who has got superimposed pneumonia. Anybody with ARDS now, the same treatment as mostly as this SARI, but now the Medacivir is also being authorized to be used as a part of the research, but recently has been clinically approved by FDA, so it's been used now for anybody with severe pneumonia ARDS. The Medacivir is also added. This is a brief guideline. I don't want to give too much details about anybody dealing with hypoxia or respiratory failure, but as a frontline, if you're in a clinical setting, in your clinic as a family physician or at a medical center or an ED, it's good to have some idea about how can you buy time until you get some more support from critical care or anesthesia colleagues to come and manage their airway or hypoxia. But we need to follow some guidelines in order to prevent yourself or the staff not exposed to a high-risk COVID-19 patient. So anybody who is not crashing, obviously you can manage their low sats by starting with a simple nasal prong with 4 to 6 liters per minute, but make sure you have them under a surgical mask. It's an industrializing oxygenation, so you can't put yourself and others in a risk. So it risk reduces a little bit if you put a surgical mask over a nasal prong. So you escalate in a stepwise manner. From nasal prong, you can go up to non-rebreathe mask at a 15 liter, also over a surgical mask and nasal prong. And then if you have facility, you can go up to high flow nasal cannula under surgical mask and then proceed to NIV. But if you're proceeding to NIV, it means the patient is obviously deteriorating and will need RSI intubation and ventilation, so you need to call for help. And in other cases, if the patient is crashing, you don't have time to obviously try nasal prongs or breathing mask. You put the oropharyngeal airway. You can use a bag valve mask, but you need to use it with a two-hand technique, so you make sure that the mask has a very good seal over the nasal prong, so you're getting no leak and not exposing yourself or anyone around you. And you can just use it with full open oxygen and with PEEP at 10 until you get some more help. So this is just a very brief outline about managing hypoxia, respiratory failure in the front line until you get some more help to get definitive treatment. But just following this, you can just prevent patient from desaturating and buying some time, and also protecting yourself and team from not exposing to a COVID-19. Just remember with patients with low SATs, when they are actually a bit alert, but you can also try awake proning, and it is found to be very effective, improving the saturations. So if the patient can able to do it, then you can obviously use proning while nasal prong is on, and it has found to be improving the saturations. The home quarantine guidelines for the patients which go home. I'm just sharing this. It's a long slide with a lot of points. I don't want to go in detail with every point, but just to show you what are the guidelines we're giving to the patients here. So we tell them obviously the reason why they are being quarantined and they have to be at home for 14 days or more if they have symptoms or they have come in contact with anyone with the symptoms or being exposed to COVID-19. And then there are different criteria. We give advice on everything. So there's a criteria of to give them advice for home quarantine, how to prepare. So just briefly, like they have to be prepared for 14 days. They have to have supplies for 14 days. What they need, like disposable tissues, antibacterial wipes and gloves, first aid kits, and talk to a friend, relatives. Do not live with you just to support you and somebody to help you bring the stocks. Then something about residence. That should be a single room with bathroom. You should have, I mean, all the facilities, basic facilities, water, electricity. I mean, this is just a guideline for all the patients here. They get like a leaflet when they're sent home with all these points on. And these are long, but they're obviously self-explanatory. We do give them all a small bag from Cleveland Clinic, which includes a bulk of surgical mask, a bulk of disposable gloves, and a thermometer to monitor their temperature. And they all also get an app which they got downloaded and they get tracked. And also they can contact the triage telephone line if they have worsening symptoms or temperature is persistently high or they're worried. They can, on a tap of a button, they can quickly come in contact with the triage team and they can advise them whether they need to come to the hospital or they can manage at home. They also get advice regarding family, that it's not only the patient who get exposed or is in quarantine, it's their whole family needs to stay at home because they are obviously living in close contact. And there should be only one person who is taking care for elderly or pregnant or very young children. So this is a leaflet which we give it to them. It's just a screenshot from the leaflet with lots of points there. And everybody, depending on their circumstances, like in Pakistan, you can make up their own leaflet or advice for them to go to home isolation or quarantine. At last, I'll just briefly discuss the workflow for the staff, which we follow here. The staff is obviously have three categories who get assessed for COVID-19. Either they're asymptomatic, they get tested only because they have been exposed, or we are doing random swabbing for the staff. So just to make sure everybody is not exposing other colleagues or patients. So they are doing random swabs for the whole hospital to find out if anybody is positive, and they pick it randomly. Or the staff who have mild or moderate symptoms, or the staff who are severely ill. So if they're severely ill, obviously they follow the same pathway as anybody else. They go to emergency department and they follow the same hot zone workflow, and they get through the same process. There's a COVID clinic which is set up by Occupational Health. So anybody who's asymptomatic, they go to a COVID clinic during working hours for assessment. For the staff who have got mild to moderate symptoms, they get sent to COVID clinic if they're in hours. If they're out of hours, they can go to emergency department for assessment. Anybody in the COVID clinic, they get clinical assessment by the occupational health team. They get a COVID-19 swab. They have risk assessment, whether they have got comorbidities or any risk factors for worsening disease. They get the clinic is also responsible for giving them results when available. They arrange the follow-up consultation for all the staff, whether it's virtual or personal. They use video consultations. Every 24 hours, you get a call from COVID clinic asking about how you're feeling, what's your temperature. They give you a portable SAS monitor as well at home, so you can monitor your saturations. So they look after staff very well. So every 24 hours, you get a call, and then if need, they can arrange a video consultation or personal consultation with a doctor if it's needed. And they provide a lot of support for residents as well. So there are a lot of staff, nursing staff, or the staff who are living in combined accommodation. If they become positive, then they're providing them isolated accommodation a separate room and bathroom. And then they give all the medical care, and also they're providing some psychological and support to the staff as well. If anybody found to be unstable in COVID clinic with tachycardia, tachypnea, or hypoxia, they are sent back to emergency department for further assessment, whether they need admission or more clinical input. And same in emergency department. If the patient with mild to moderate illness who attend emergency department, if they're stable, they get tests done. And from emergency department, they are sent back to occupational health for follow-up. And so they follow up on results and further monitoring. This is the process we're following here for looking after staff with emergency department and COVID clinic in combination. So in summary, at the front line, it's important to designate your areas, especially the hot and cold zone, so you don't have to mix patients and staff, and you can look after them in different areas and prevent cross-contamination. So streaming process has to be very effective and to safeguard patient and healthcare. Follow strict PPE policy, donning and doffing practice and checklists, so not expose yourself. And should have departmental guidelines for assessment and management, and everybody should follow those criteria strictly. And then again, obviously have criteria for admission, discharge, or transfer. Patient isolation guidelines are important, so they can monitor themselves and they know what they're expected to do. And obviously, it's very important to give effective and supportive care to your staff. This is the current data so far, the day before yesterday. There's comparison between Pakistan and UAE. Not far behind in number of patients, a bit different in the number of deaths. But may Allah keep us all safe and in the holy month of Ramadan. And we may come out of this pandemic soon, inshallah. Thank you very much.
Thank you very much, Dr. Mohammad Saif Rehman. Can everybody hear me?
Yes, Dr. Tahir.
Okay. Thank you very much, Dr. Saif Rehman, for your very crunch and very to-the-point presentation. And I think it's going to be a long way in the clinical practice of all the physicians working in the emergency departments and all the other family physicians who are running their own hospitals, and they have set up their emergency rooms over there. Now it's time to involve our panelists over here, but at the same time, I would motivate my participants that they can type their questions in their chat box so that we may ask their questions from the speaker and from the panelists as well. So you can write down your messages in the chat box. So it's my utmost honor and privilege to invite right now Professor Ashraf Zia, who is at the forefront and is very pertinent to our today's talk, because he's not only working in an emergency department, taking care of the COVID-19 patients, and at the same time, he's running an emergency room in his at his own hospital. Please, Dr. Ashraf Zia, please come forward and very briefly, join our participants and give your expert opinion on today's talk, and if you want to add something in that. Over to Dr. Ashraf Zia.
Dr. Tahir, I think Dr. Ashraf Zia has lost his mic. Actually, we can't hear him. So you can take comments from Dr. Tariq. Meanwhile, Dr. Ashraf Zia can handle the technology and he
Okay, okay, sorry. Thank you. Dr. Tariq Mian, can you hear me? Dr. Tariq Mian, can you hear me?
Yes, yes.
Thank you very much for joining our today's session. And Dr. Tariq Mian is the president of Pakistan Academy of Family Physicians. MashaAllah, one of the most busiest family physician in the town, is right now taking care of the patients at his clinic, even on Sunday. Dr. Tariq, can you please share your experience regarding your patients with COVID-19, and you want to add something from the perspective of the emergency department and for your family physician colleagues, whatever you want to share over here, you can share. You are welcome.
Yes, thank you very much, Dr. Just I want to share two things. That the patient who has recovered from COVID-19 and he is now negative is not equal to or not equivalent to the patient who has never diseased with the corona, because I have seen two patients. They were admitted in Mian hospital. They became negative, but I think 4 or 5 days later, he came to me with breathlessness. I just have his X-ray chest, and he was having a lot of cardiomegaly. So I think this post-COVID cardiomyopathy, this is one of the things we must take in mind if the patient comes to you with breathlessness. Secondly, I have seen many patients who were negative by the test, but they were clinically and radiologically, they were just like a corona patient. So I think if there is any patient who is negative on the testing, because we in Lahore, we were testing by 2 or 3 labs, and they are testing 2 antigens, while some government hospital, they are testing 3 antigens. So if there is one report, and there was just a video by some person that he was saying that 3 or 4 labs have given negative test, and one government lab has given positive test. So I think the difference is that they are testing 2 antigen, and in government hospital, the latest kits is testing 3 antigen. So this is just 2 important points I want to share with my colleagues.
Thank you very much, Dr. Tariq Mian. And I would like to take Dr. Mohammed Saif Rehman on board right now to add something to Dr. Tariq Mian's comments right now.
Yes, I agree with him that there are a few patients who present later with complications, even after having a negative swabs, and we have seen similar things here as well. And patients coming back with more shortness of breath or developing failure, even despite having negative swabs. The thing with the swab test is sensitivity is not very high. It's not very, patient have had negative swabs and positive swabs a few days later and then negative again. So we go by mostly the clinical criteria. So if they have COVID positive chest X-ray or CT scan, we just treat them as a possible viral pneumonia and COVID. The swabs are not very sensitive. And so the policy here is that everybody who's having a positive swab, they get followed up, they get a swab on day 6 and day 12, and they have to have 2 negative swabs 24 hours apart before they get declared they are negative.
Thank you very much. So what I can grab from this talk is that we must be mentally prepared for post-COVID cardiomyopathy after the attack is over. Now it's time to involve Dr. Professor Ashraf Zia. Thanks, Dr. Professor Ashraf Zia, for joining us. And you are at the forefront, and I personally know that you are fighting day and night at your unit with your very esteemed team with the COVID-19 patients. So your take would be very valuable for us. Please go ahead and share your expertise. Over to Professor Ashraf Zia right now. Professor Ashraf Zia.
Sorry, first of all, thank you very much to Firoz Sands and Pakistan Academy of Family Physicians for providing this very valuable forum. And I have listened to the whole talk of Dr. Saif, and it was very informative and very useful talk. We in Pakistan have almost same criteria of referring the patients. We have tried for OPD patients, and we have emergency setup for COVID patient. One thing which I was just listening to Dr. Tariq Mian, that patients which are having negative tests on PCR, even then they are having COVID